So just a little bit of my background. I actually grew up here in South Portland, and then I went to URI and received a pharmacy degree, and then went on to NYU to get a PhD in pharmacology, and then came back to the state of Maine, worked for as a pharmacist for a while. I've been a licensed pharmacist for, it's hard to believe, 25 years. Did some research at Maine Medical Center Research Institute. I also did a postdoctoral fellowship at the University of Washington before coming back to Maine. Then I was chair of a pharmacy technician program at SMCC, and then came here to be the founding associate dean for the College of Pharmacy, and stepped down from that position a couple of years ago to do more research and to do more teaching. So I've also served as an expert witness for about a dozen years, more so in the last 6 or 7, when a company in Massachusetts called Healthcare Litigation found me. They were looking for a pharmacologist and did a Google search, and I guess I checked off all the right boxes for them, that I was a pharmacist and I had a PhD and was associate dean. And so why do I do this? Because it can be rather stressful, and before I get to this, when you look at this title, some of you may say, well, that contradicts itself. How can healthcare litigation, suing people, improve the interprofessional approach to reducing medical errors? And I hope over the next hour and a half, I can convince you that they do go together, that through our legal system is often where changes are made. So first and foremost, I do it to help individuals. And I'll show you a list. I've done more than 24 cases, and I really believe that the majority of those that I've written opinions for and that have progressed to depositions and trials, that the individual was helped by my involvement in the case. At least that's what you hope. Also to improve the healthcare system and patient care. Again, until things are you shine the light on it, and until there's an environment where people feel comfortable reporting errors, you're still going to continue to have this healthcare litigation go through, and yes, there's lawyers involved and lots of money, and it's, I'll go over an imperfect system, but I think it's the best one that's out there, and I think it does work over time. And then intellectual curiosity. I just got a case, I don't have a case, someone called me yesterday about a fairly new drug that's on the market called Nuvigil, and I am familiar with the class of medications, but not that particular medication, so I immediately went into references and started learning. And I think that's part of what we try to do here at UNE, is to foster that lifelong learning, and certainly this is a way to approach it, because every new case presents with things that you've never encountered before. So the experience, you can read the list of cases that I've done, and we'll talk about a few of those today. So everything I'm presenting to you are actual cases. And obviously the majority of them, 24 or so, are malpractice cases involving healthcare professionals. What have I learned through this? Litigation can happen to anyone. The first case I ever had was a gentleman and his girlfriend had gone out to dinner and had a few drinks. It was a snowy evening here in Maine. They stopped short before a bridge in his pickup truck. It skidded in and hit the support of the bridge. He was wearing a seatbelt and he was fine. She was not wearing a seatbelt. She hit her head on the dashboard and died. When the police showed up and did the report, and he passed a field sobriety test, but when they opened up the glove compartment, they found a legal prescription for opiates, which then brought it from manslaughter to aggravated manslaughter. And then I was brought in to do the pharmacokinetics. So you're familiar with pharmacokinetics? It's what the body does to the drug, how it's absorbed and distributed and metabolized, and looking at his blood concentration and when he reported taking his dose, and looking at the half-life of the drug, determined that there was very little of that opiate left in his system at that time. And the fact that he did pass a field sobriety test, it was knocked down from aggravated manslaughter to manslaughter. He still went to prison for 2 years, and I think he served about a year and a half. It's an imperfect system. The second case I ever got was an appeal of a murder case. A lawyer contacted me. He had defended a client, awful situation. A woman was dating a man, they broke up, she started dating a new guy, convinced the new guy to go back to the old guy's house to get her stuff. The new guy bangs on the door, the old guy answers the door, takes a gun out of the stove and shoots him dead. So the lawyer defended the case, he went to jail for murder, then on appeal he was granted a lawyer, and the lawyer found a retired pathologist in New Hampshire who was willing to testify that when they did a drug screen after he was arrested, there were diazepam, Valium, and THC, the active ingredient in marijuana, in his system. And this pathologist was willing to testify that in a very small percentage, both diazepam and THC make you aggressive. And because his lawyer did not find an expert witness to testify to this, that was the grounds for appeal. I then wrote an opinion and said, well, if you take Valium, you hyperpolarize cells. And if you take THC, you hyperpolarize cells. And if you take them together, you're likely to hyperpolarize cells even more and require a greater stimulus. And that, no, it doesn't make you aggressive. If anything, it makes you sleepy. And thankfully, that was thrown out. But your tax dollar is hard at work. You can't blame the guy, and I don't blame the guy sitting in prison for filing the appeal, but this retired pathologist, I only take cases, and I'll talk about this, that support my professional opinion and judgment. I'm probably 20–30% of the cases I'm telling the lawyers, you don't want me as the expert witness. If anything, I'm going to cause more harm to your client than good. An example of this, I was contacted by a lawyer. A gentleman was arrested for disorderly conduct at a fair, and when they searched his pockets, they found a plastic bag with a half of a white tablet, and when they did the drug analysis on it, it was methylphenidate, Ritalin, and the lawyer wanted me to make the argument that he was legally prescribed oxycodone, and that both oxycodone and the methylphenidate were small circular white tablets, and that there could have been a situation where the pharmacist misfilled his oxycodone prescription for methylphenidate. And I said, I think I would do more harm than good if you put me on the witness stand for your client. So learning objectives, first we'll talk about, so obviously being a PhD in pharmacology, I'm brought in to do cases that involve medications. And we'll talk a little bit about the cost, both human and financial, of medical errors, and in particular, those resulting from medical errors due to prescriptions. Define liability, duty, malpractice, and negligence, and then try to identify problems in the delivery of health care, especially the transition of care from one environment to another, and try to describe methods to decrease medical errors by improving interprofessional communication in medical records. And that's where I really want you to work on when we break into the small groups. And I think the take-home message here, you can read through, 156 million physician visits, 23 million ER visits, 11 million hospitalizations. What really jumps out to me, the annual cost of medication-related morbidity and mortality is $290 billion, which is more than the cost of the medications themselves. And in Maine, you're dealing with, $1.7 billion. There are three types of liability: criminal, civil, and product. You can read through the descriptions. The big distinction is most of the cases that I do are civil liability, and you have a different, when you're presenting the evidence, there's a different bar. It's what they call more likely than not. So this event took place more likely than not because of the mistake or the error in judgment or the practice, which is different than criminal law. Criminal law, you have to prove beyond a reasonable doubt. Malpractice is negligent misconduct, lack of ordinary skill, or a breach of duty in the performance of a professional service. So each of you have a duty, and once you become licensed as that healthcare professional. And if you look at the negligent versus intentional act, the negligence is the failure to exercise that degree of care which a person of ordinary prudence, practical wisdom, caution would exercise under the same circumstances. And surprisingly, the laws are very different from state to state in terms of the expert witness. So here in the state of Maine, I have testified in cases against someone in a different healthcare profession. I have a case that I'm going to be flying down to Louisiana to testify, where in that state, I cannot testify against a different healthcare professional. I can offer my opinion, but then they need a healthcare professional. If it's a physician, you need another physician to be able to contradict. And it speaks to that person's practice and expertise. I'm being brought in to speak just to the pharmacology, not to the administration of the drug. They have a physician for that. So difference between negligence and intentional act. Example is a broken nose in a car accident versus a punch. If you're driving in a car and you aren't paying attention, you're texting or whatever, and you glide through a stop sign and you hit somebody else, that's negligence. Intentional act would be that person in the other car gets out and punches you in the nose. Get the difference between the two. In a case of negligence, you have to prove first four things. First, did that healthcare professional have a duty? And in the profession of pharmacy, that duty would be obviously to fill a patient's prescription correctly, but also, starting with the over 90 laws, as pharmacists, we have a duty to counsel patients and perform a drug regimen review. So every new prescription, you're either supposed to be asked by a pharmacist whether you want counseling or being provided counseling. That happens every time you fill a prescription, right? Breach of that duty can be two things. Nonfeasance is the duty is not performed. Malfeasance is the activity is performed but is incomplete or incorrectly done. So that's when they bring in an expert witness. Then I draw upon my own experience, laws and regulations, code of ethics, what's out there in the literature to determine whether that person, and that's often what I'm asking myself. If I was that pharmacist working in that same environment, would I have done things differently? And then harm. Most states you have to prove that there's some sort of physical injury. Are there any lawyers in the audience? If you talk to lawyers, you might get a different answer. One of the guys that, the way it works with this healthcare litigation, they act as a repository for expert witnesses. So a lawyer from the entire country can call them up and say, I have this case that involves medication, then they contact me. I usually have a short conversation with the lawyer to determine if it's a right fit, and then they often pay me for a few hours to go through the medical records. We touch base again, and then it can progress to me writing an opinion and deposition and then testifying in court. So out of the 24, I've probably done 7 or 8 depositions and testified in 3 cases at this point. The 4th will be in July. So if you talk to that lawyer, he'll tell you, oh, misfill of a prescription, that's $10,000. Well, where did you come up with that? And just because you misfill a prescription doesn't mean that you're liable. I mean, if you misfill the prescription and the person brings it home and notices the mistake, no harm is done. Or if they take the medication and say it was an antibiotic instead of a blood pressure medication, and they caught it fairly quickly, and there was no harm done by taking that antibiotic, then I would say that they don't have a case. It can be difficult to separate the symptoms associated with the negligent act from the patient's underlying pre-existing condition. This is where it muddies the water and becomes much more gray. Proximate cause means that the negligent act you can tie directly to the harm that was caused. So this becomes difficult with medication cases to figure out if they actually took the medication. but sometimes it's readily apparent. There was a case where I had with a misfill. The woman was supposed to receive amoxicillin and she received an antipsychotic. She then went home. She looked at the receipt that was on the bag and everything was correct, but the medication bottle inside was from a different patient. So the prescription was actually filled correctly. They just put the wrong vial in the wrong bag with the wrong receipt. And she read the outside, saw it was amoxicillin, and then didn't read the vial. She opened it up, took the medication, went for a walk with the dog, came back, started experiencing all of these CNS symptoms, was trying to have a conversation with her husband and was unintelligible, and they brought her to the ER, and she was fine over time, but they incurred costs from the ER and on the visit and all that, and they were just looking for compensation for that. And the pharmacy knew they made a mistake because when they must have found the other vial and the other receipt, and when she called up, they immediately sent somebody there and gave her the new prescription, took the old prescription back. But then when they looked for compensation, the pharmacy immediately lawyered up and didn't want to do anything, and then started creating obstacles, where I believe if they had just paid for this woman's hospital bills, all of these other lawyer costs would have went away. So for example, a good example of this proximate cause, if I misfill your prescription and you go home and you open it up and say, geez, this isn't the right tablet, and you call me back and I say, well, I really apologize, could you bring it back? And on the way back to the pharmacy, you get in a car accident. That's not proximate cause. The damage was not caused by the misfill of the prescription. You read through specific to ours that I think some of these are pretty obvious, but if you go to the last bullet, dispensing a drug that's contraindicated with one or more current medications the patient is taking with no physician order approving the simultaneous use of both substances. And I've run into this quite a bit with pharmacy, that it comes down to what would a pharmacist be doing in that situation, and were they negligent? Did they not do what they were supposed to do? And I'll present a few cases at the end of examples of this. So the first interactive case is a 19-year-old African-American with a history of sickle cell disease. He presented to the ER complaining of chest and bilateral arm pain at 1:45 a.m. So those of you not familiar with sickle cell, when they go through these crises and once the red blood cells sickle and they're no longer that biconcave shape that can tumble and squeeze through capillaries, these sickle cells tend to stick in the capillaries. So it's very common that they would present with this diffuse pain. Everything was pretty much normal, but you see his oxygen saturation was low, which makes sense. He was, having a tough time distributing oxygen when he went through this crisis. So they started on diphenhydramine. He had some rash and itching associated, which is very common. They couldn't immediately place an IV, so they gave him 2 tablets of Vicodin, and then they paged a phlebotomist, who then set up the IV. And then you can see, I put in the times so you'd see the timeline. They started with 5 milligrams at 2:52 a.m., 10 milligrams at 3 a.m., 3:10, 3:20, 3:30, 3:45, 3:55, 4:05. He received 75 milligrams of morphine over 73 minutes. He was also given ketorolac. If you're not familiar with that, it's a non-steroidal anti-inflammatory drug that's been shown to allow you to decrease the amount of morphine that you give and produce the same analgesia. The patient was awakened from sleep and re-examined at 5:30 a.m. His lungs were clear and he had an oxygen saturation of 99%. He was discharged to the hospital at 5:30 a.m. When you read the records, it turns out that's when their change of shift was. And they literally woke him up, and the girlfriend literally carried him to the car. He was found unresponsive by his girlfriend at 5 p.m. They called the EMTs. They arrived. His pulse was 54. respiratory rate was only 4, and oxygen saturation was only 48%. He was intubated, but then pronounced dead at 6 p.m. Autopsy was performed, and they deemed it was due to vascular occlusion as a consequence of the sickle cell disease. When they looked at his lungs, he had multiple pulmonary emboli. In toxicology, he had morphine blood levels that were sufficient enough to produce anesthesia and potentially toxic. Additional information, the pain index was initially 9 out of 10. It became 3 out of 10 after the 3:45 a.m. injection, but they continued to give that 3:45 a.m. injection and 2 more. And if you're familiar with sickle cell disease, you're never going to get that patient down to a 0 or a 1 or a 2. I mean, this is the best that you can accomplish in that acute attack. They were initially unable to find the vein that I talked about, and they gave the Vicodin. What's wrong with that picture? What's that? It has an opiate in it, but what about the dosage forms? They gave him an oral med, right? That's going to take 20, 30, 40 minutes to get into his system and reach peak blood concentration if he has an empty stomach. Then they immediately put in a vein and gave him morphine on top of it. You know, to me that makes no sense. Why wouldn't they just wait till the phlebotomist showed up? And the patient did have a history of respiratory depression after opiate administration. To be fair, they didn't know that. It had occurred at another hospital in the area, so they didn't have that information. But I can tell you, if you looked at these medical records, it looked like they took a chicken and had him step on a ink pad and then walk over incredibly hard to read. I was reading probably a copy of a copy, but the medical records were all handwritten and they were a mess. So that's what I'd like to do now, is stop, have you get into smaller groups and discuss 3 things. We'll take no more than 10 minutes. How did the morphine contribute to the patient's death? More importantly, I think, is how could this have been prevented? That's what I really want to accomplish here, is get you talking about how do you fix, or after the error has taken place, how do you fix the system and hopefully prevent errors of this nature in the future? And then you're going to act as like a mini jury. Who do you think is liable in this situation? And check the boxes, and if you think it's all of the above, you check all of the boxes. So like I said, if you can intersperse, and then once you do that, stay in those groups, stay put, because we're going to do 2 more. Well, I hate to break up the great talk here, but we've got 2 more that we want to do. So you can basically stay where you are, because I'm going to present another case and then let you talk again. But let's talk about this one. So any ideas at how you... I wrote an opinion, I can tell you, that said the morphine contributed to this patient's death. And the fact that he received that high a dose over such a short time period, I felt was negligent. So any guesses as to what's happening with the pharmacology with the morphine that contributed to the death?
We do have the camera running, so we need to use the microphones, and Dr. Kopak and I have microphones. We have a hand over here, or were you scratching your head?
We've got one here.
So we were talking about how obviously the patient's respiratory depression definitely contributed to his death. But also,
exactly. So what's going to happen with the respiratory depression? What's that going to do with the level of his red blood cells?
They will go up.
They will what?
He'll get more.
Oh, well, long term,
That'll
but
be
in the
long-term,
acute
yeah.
situation.
Oh, they'll, yeah.
There you go. So with the hypoxia, you're going to get the red cells sickling more, which I believe is what contributed. And I was really surprised that that wasn't in the autopsy report, that they put natural causes, but they're basically looking at the body and figuring out where any lesions are. But I firmly believe that that's what took place, that they gave him too much morphine too quickly. I mean, I couldn't find anywhere in the literature where you give more than 10 milligrams quicker than every 4 hours. And he received 75 milligrams in 73 minutes. So, you know, to me, this was very clear cut, but the lawyer was really worried about, I don't often find out what happens to these cases, because after they're in close contact with you and you do whatever you need and then you never hear from them again. So I don't know what happened to the case, but it seemed to me that it was pretty clear cut. Who did you think was liable in this situation? Oh, did you have another comment?
So do you think the analgesia from the morphine would have prevented like the patient realizing that he was getting a pulmonary embolism?
Absolutely.
Because it's supposed to hurt.
Well, when a normal person that goes into hypoxia is, like you say, is very painful, and then they would wake up and they would start breathing more and compensating for that lack of oxygen. But you're correct, that level of anesthesia, he never woke up and never had that air hunger, that normal hypoxic response that you would see. So who do you think is liable in this situation? The physician, nurse, hospital, or all of the above?
We said all of
If you want to grab the microphone.
We said all of the above. We said the physician because he should have put a cap on the order, been more specific for clarification. And then we said the nurse due to communication, because they didn't communicate between the previous nurses and the ones with the next ones. And then we said the hospital, probably because they should have better rules for documentation and like preset orders potentially for
To jump back to the nurse, it was the same nurse that gave all the injections.
Oh.
So
Yeah,
I
she
jumped
should've
there,
double-checked with the doctor.
now let's go back, get that sort of liability out of the way, the blame game, which I don't think that's what we're here about. It's more about how do you fix things. Now let's go back, how do you think this could have been prevented? So you spoke to a few things, that you could have more specific orders and start and stop times. What else?
The nurse should have questioned the orders. Like, if she's been with the patient for X amount of hours, she should know, like, okay, this isn't right. I mean, as a nurse myself, I would have asked the physician, this doesn't seem right. Can you look at this?
Absolutely, and that speaks to multiple professions seeing the prescription order and not just rubber stamping it. So one of the things that takes place at Maine Med is that every prescription order goes down electronically into the basement, and there's pharmacists there sitting in a windowless room, and they check every single prescription order. So if this hospital, small hospital in Illinois, had the same system, I would hope that a pharmacist would look at this and saying, what are you doing? This is way too quick and way too much medication. Or that a nurse would take it. And at Maine Med, when you put in those stop and start orders, they now have a barcode system. Everything that passes a red line in the pharmacy gets coded with a barcode. Then that barcode is put into the system, and then the barcode on the patient's wrist is in the system, and then the nurses scan the wrist and scan the medication to make sure, first, they're receiving the correct thing, and second, they're getting the proper dosage regimen at the proper time. And if they are out of that window when that patient is supposed to receive it, they receive a halt. And then the pharmacy collects all of this data, again, to help fix things into the future. And then they can look at it over time and recognize the mistakes that are being made and then implement procedures to correct those mistakes. And by doing that, they've dramatically decreased their medication mistakes.
I just wanted to piggyback on the last comment. It could be prevented if the hospital creates an environment where it's conducive for the nurses to question the physicians and make patient safety the priority, and so that nurses feel comfortable, because they can be a great safeguard.
Absolutely. I did a case that involved a pharmacist with home infusion, and it was a diabetic patient that was receiving an aminoglycoside, an antibiotic that can cause kidney damage and damage to the ear, both hearing and balance. And they didn't order blood levels, which they should have. With aminoglycosides, the guidelines say you usually take a blood level 4 hours after giving the IV infusion, and then you do the pharmacokinetics to get in that therapeutic window where you have enough drug to kill the nasty, I think it was this methicillin-resistant Staph aureus infection in his foot ulcer. You need enough medication to eradicate that infection, but you don't want too much where you go into kidney failure and the ototoxicity. And the person experienced diminished kidney function and then permanent balance problems and now has to walk with a walker. I was hired by the lawyer who was trying to defend the pharmacist, and there wasn't much defense there because the opposing counsel brought in specialists who do this home health care infusion and said, absolutely, we always see that there are orders to take the blood levels before we dispense the medication, and if there aren't, we call the physician and get them and make sure that they're implemented. So it was a situation where I didn't work anymore on that case because, again, I wasn't going to help them with what they were doing. But that's part of my job as well, is to present, even if it's a case where my opinion is not going to help them, I can present scenarios to them of what the opposing counsel is going to do. And that often, I think, pushes them to an early resolution and paying out what they're going to pay out because they recognize, okay, the case against us is too strong and it's better to just settle. Okay, the next case, just going through what we went through with the hypoventilation and the hypoxia. Again, if they had just kept the patient at the hospital and monitored his oxygen saturation and respiration, they could have again given an opiate antagonist and reversed the effects, and he would, I believe, he would not have died. And again, the verified pharmacist verified the order, or some other healthcare professional stepping in, the nursing or another physician, someone to say, this is too much morphine in too short a time, and or this person should not be discharged from the hospital and sent home. So the second one is a 78-year-old female that had had a stroke as she was home, living an active life, had a walker, so she had some imbalance going on. She put the walker in the hallway to go to the bathroom. She fell and broke her hip. She then presented to the ER. They then scheduled a surgery. She was on Plavix to prevent a second stroke. The cardiologist was brought in. He deemed her well enough to have the surgery, discontinued the Plavix so that she wouldn't bleed too much during the surgery. After the surgery, she was put on Lovenox, a low molecular weight heparin, to prevent deep vein thrombosis. She was discharged to a skilled nursing facility where they started to, once she had healed enough, they started to get her up doing physical therapy. And once she was ambulatory, the protocol says that you stop the low molecular weight heparin because now she's ambulatory and less likely to have the deep vein thrombosis. They did not, Plavix was discontinued on 8/27, and then 2 days before the surgery, and then the timeline, it was discontinued on 9/20, and then the patient suffered a second ischemic stroke on 9/30. And you look at, I picked this case because it speaks to the transition of care. So she had a primary care physician, an admitting emergency room physician, an orthopedic surgeon, the cardiologist who did the consult to clear her for the surgery, the physician at the skilled nursing facility, a nurse practitioner at the skilled nursing facility, and then a consulting pharmacist that was required to go through for purposes of federal Medicare. They go through all of the prescription orders. So the question for you, again, in your little group, what could have prevented the second stroke? How could the transition of care be improved? And then again, addressing the liability issue. So why don't you take another 5 minutes or so on this one? Katie, you feel comfortable talking about this one? So what do you think could have prevented the second stroke? putting her back on Plavix, that's a pretty easy one, right? She was off the medication and put on the Lovenox that probably provided, even though the primary indication is for deep vein thrombosis, if you look in the literature, it was probably providing her benefit for a cerebral stroke as well. But certainly right after she was discontinued with the low molecular weight heparin, the Lovenox, the Plavix should have been started. So how could the transition of care be improved? Any ideas? Because this happens all the time, right? You go into one facility for something acute and then you're switched to a different floor within that same facility, that you're going from the ER, maybe the ICU, and then you're up on a regular floor, or you're being transported to a rehabilitation facility or skilled nursing care, or, and then the transition again to home, which doesn't involve in this case, but I think is relevant to this discussion. So what do you think that you could do to help with this transition of care? Better communication in this, again, medical records that then have the start and stop dates for medications. And there's there's lots of systems out there now that would say, stop the Plavix, start the Lovenox, stop the Lovenox, start the Plavix, and that they would be given alerts to when those things that would be taking place. Any other suggestions?
I think a lot of it has to do with the consultations of specialties, the continuity of care. A lot of times you have specialists come in, like in this case, the orthopedist, the cardiologist. They come in and sometimes they'll do just a quick snapshot of what they think the patient needs and then just leave it at that. Sometimes it's just a verbal discussion with the primary instead of a written order, and somebody else comes on and there's no mention from cardiology or nephrology of what the plan is, and the patient gets lost in the shuffle. So medication reconciliation is huge, knowing what the patient was taking when they first came in, and then we are responsible to make sure that either that's addressed before they leave and updated or changed or DC'd or something. But
Right.
the
So
physicians talking to each other.
Are you all
is
familiar
key.
with that term, medication reconciliation? It's basically when the patient moves from one environment to another, somebody is actively going through each medication and seeing medication to determine the indication for that use and to update the dosage of that medication, because you often see that a hospital formulary may not have the same drug. Say they're on a statin to lower cholesterol, may not have that same statin, and they're changed to that. And we see that as pharmacists, they then go home and they don't know, and now they're taking two of the same medications in the same class. So again, it speaks to professions working in a silo, even within the same profession. You had a primary care physician, orthopedic surgeon, a cardiologist, and the physician at the nursing skilled nursing facility. They're all in the same profession, but they're all working in a silo and not trying to break down that barrier and make sure that there's a patient continuity. And people always use the excuse, well, we're really busy. When you looked into this case, the nurse practitioner was the only one that saw the patient, but the nurse practitioner was working under the physician, but the physician never actually saw the patient. And when they talked about their procedure for the day, they would get all these orders and they would literally cut them in half and fly through them and sign them. Hundreds of orders a day. Obviously not the situation that you want. And you say, well, if they implemented the system, it would cost too much. I don't think so, because you're already paying out, we just talked about $290 billion a year to pay for the problems from medication errors. I think there's more than enough money to implement the system and to hire more staff to then save the entire system. And I think it speaks to a sea change, and hopefully a lot of this is going to take place with Obamacare, where you're paid to keep people well. You're not paid to tune them up after they're sick. You actually receive compensation for consultations and for keeping people within normal, healthy limits, and you're actually compensated for that.
This case is similar to the last case in our discussion about there needs to be a shared protocol within the culture so that having a check-back mechanism that's in place that could take 2 minutes between each transition, but that everybody knows what that is and everyone needs to do it, and there's some accountability for checking off of having, communicated effectively and have the opportunity to ask questions about the changes that are taking place.
She's like a plant, because that's what coming. So it's restarting it, and I believe the liabilities with both the physician and the skilled nursing facility, and if you look at the collaborative practice agreement with the nurse practitioner, I believe that he had liability as well. And if you're under one of those agreements, make sure you read them, because someone like me is going to read them after the fact, and if you haven't read them and you're not doing what you're supposed to be doing, by definition, you're negligent. And they talk about that medications, that there was supposed to be a plan developed, and part of that was medications, and that if there was anything that veered from a normal protocol, so the normal protocol would be to restart the Plavix after the Lovenox was DC'd. The nurse practitioner, if they're making that decision on their own, they then have to run that by the physician that they're working in. And again, it's dependent, this one was in Louisiana as well. It's dependent upon your particular state. So my advice to you is make sure you read the rules and regulations of your profession, and that if pharmacists they just passed a law that allows us to have a collaborative practice agreement with physicians. You pharmacy students, make sure you read those things with a fine-tooth comb to make sure that you're doing what you're supposed to be doing, and more importantly, you're not doing things that are out of your scope of practice. And then I think went through most of this. So possible solutions. We hit upon the better documentation, and then I think what Shelley talked about is being done at Maine Med. So if you are a patient of the outpatient clinic at Maine Med, and you go to the hospital and you're admitted, when you're discharged, they then have a follow-up visit with you with a team that involves physicians, nurses, and pharmacists that help with the med reconciliation, and by doing that, they've decreased the amount of readmits, I think, by 13 or 15%, which doesn't sound like a lot, but when you think about how much one day in the hospital is thousands of dollars for each of those patients, it's a tremendous savings. And more importantly, better outcomes for the patient. They're not coming out of the hospital, going home, having a problem, and then being readmitted, and this continual cycle. Because we all know hospitals are not where you want to be, with nosocomial infections and all the other things bad things that can take place when you're sick, sitting in a bed, immobile. And then again, the electronic medical records with the recorded stop, start, and restart dates. That really surprises me. And again, I hope this is a consequence of Obamacare. A lot of people like to bash it, but one of the things that's been taking place is that they're paying healthcare providers, physicians, dentists, optometrists, anybody who's out there, to switch over to electronic medical records. They're actually providing incentive for them to do it. I have a buddy who's an optometrist. It took him really a year and a half to convert over, and it was terrible, and the guy was working all the time. But now you talk to him, he doesn't know how he lived without it before. Before they had a room, it was a big practice, it's a big practice in Lewiston. They had a room, he showed me, it was about the quarter of this size with just all of the paper records for all of his patients. That all now goes away, and they're able to provide much better care through electronic medical records. Pharmacy, we've had prescription medication software since the early 80s, late 70s, but you go into a hospital and everything is handwritten? To me, that makes no sense. The last interactive case is brief, and it deals with the pharmacist. It's an 80-year-old woman who has 2 oxycodone immediate release tablets prescribed for back pain over 3 months. It should be 2 prescriptions prescribed for back pain over 3 months. And it was 1 or 2 tablets every 4 to 6 hours is needed for pain. The physician then prescribed a 25 microgram fentanyl patch. If you're not familiar with them, you put them on the upper arm or the back, and it delivers the medication slowly over 72 hours. Patient fills the prescription once, and then the physician increases the dose to 50 micrograms. During the second one, she went into an opiate-induced coma for several days, and she had to be intubated, and she died of something different 4 or 5 years later, but during that 4 or 5 years, she continually had to be intubated and receive food through the intubation. So obviously her quality of life and pain and suffering. So they were definitely going after the physician, but then they approached me, should they go after the pharmacist? So if you could take just a few minutes and talk about, do you believe that the pharmacist is negligent? And it also speaks to some of the other cases. For example, the previous case, did the nurses, they may not have by the law had the liability associated with that, but should the nurses have some responsibility for looking at that chart and seeing, well, this person was on Plavix, off of Lovenox, and should we start Plavix again? And again, it speaks to that, I think you talked about it, the environment that is necessary to allow that communication. That when you catch an error, it's reported. Most chain pharmacies now, if you don't report a medication error, that's grounds for dismissal. They will fire you. If they find out that you made a medication error and you did not report it, they will terminate you, which is harsh, but I think it does create an environment where it allows pharmacists to say, hey, I made a mistake and here I reported, and then implement things simply as, well, these 2 medications on the shelf come from the same manufacturer and they happen to be alphabetically right next to each other, and they noticed that mistakes were being made because of picking errors. They're too similar and they're right next to each other, and that's happened in pharmacies. And then they send out a memo to everybody and say, okay, reshelf this medication away from it so that you don't make that picking error. So if you want to take, again, just a few minutes. Yeah, this was one that I didn't take this case after finding it out because it's difficult with this. I don't know what I would have done in that situation. But I think it's worthwhile bringing up another case really quickly. This was a 60-year-old female with a list of all kinds of things. What jumps out is obstructive pulmonary disease. And then she was found dead at home. And when they did the autopsy, they found a fentanyl patch on her. And instead of putting it on her upper arm or back, she put it in her sacral region. They literally found her leaning against the bed, had died. On autopsy, she had, in addition to the known respiratory problems, she had what looked to be a fatty liver and diminished kidney function. So the death was cardiomegaly and poorly controlled diabetes, and the contributing factor was the fentanyl intoxication. You know, out of the 24 cases I've done, I'd say 25% of them have to do with fentanyl. So you want to be very careful when dispensing this medication and prescribing this medication. You see she was on an Advair discus. That immediately should jump up and say, okay, you have to be careful prescribing an opiate to somebody who already has respiratory problems. The attorney was actually looking to file a wrongful death against the company, claiming that the manufacturer of the product was defective. They did not have the patch that they removed from her on autopsy, and then I asked, well, do you have the box of the remaining patches with that lot number? And they said no. And I said, and then I looked at the FDA. You can actually go to the FDA website, and they have recalls. And there was a generic manufacturer of fentanyl that had a recall around the same time, but it was not this company that produced this. So this case didn't go any further because I said, well, you know, without the patches to test and without any sort of recall with that lot number, I don't think you can prove that the company was deficient. But I think what took place is that, you know, this person receiving it and the previous patient, you need to make sure that if you're going up to 50, 75, or 100, that the patient is already tolerant on opioid therapy. And tolerance means that they're receiving the equivalent of either 60 milligrams of morphine per day, 30 milligrams of oxycodone, or 8 milligrams of hydromorphone for a week or longer. If you looked at her prescription record from the previous patient, she had received a couple of small quantity oxycodone prescriptions before going to the fentanyl. Usually you're going to fentanyl because somebody has already been on opiates for a very long time and they're a terminal cancer patient or, you know, an extreme amount of pain and they've already become tolerant on opiates, and then you go to the fentanyl patch. But how do you know that she wasn't receiving other prescriptions at other pharmacies? And he could have done the due diligence and called and made sure and said, well, do you really want to be on, you really want this patient to be on fentanyl because based upon my record, she's not opioid tolerant. But I don't know if I would have caught that as a pharmacist. Then if you look at this, I probably would catch it now because now I'm sensitized to fentanyl. And I'm hoping by just talking about this, you will be sensitized to fentanyl. That when you read the black box warning with these, we use a reference called Facts and Comparisons, but you can find this in any reference, that you want to be careful with external heat sources, heating pads, electric blankets, heater, tanning lamps, sunbathing, sauna, hot tubs, heated water beds. And remember, she put it on her sacral region. So just extra heat in that area could have sped the absorption. You also, even a simple fever, you know, maybe she had an infection and her fever was elevated. And then also at the bottom, soaps, oils, lotions, alcohol, or anything else can speed the delivery. So you could imagine a worst case scenario, she takes a hot bath, increases her body temperature, puts lotion on after the bath, puts the patch on the sacral region, sits down and watches TV, and maybe she's got a heating pad, or maybe it was hot that day, speeds the delivery, becomes sleepy, walks to the bedroom, and that's where they find her leaning against the bed. I put in all kinds of cases in case I ran out of time. I think with this one, we could do this one real quick. You had a 17-year-old that experienced mental status changes after having 3 concussions. He played football, had a concussion. 2 weeks later, they let him back into the game, gets a second concussion. Now he's experiencing mental disturbance changes. Goes with his buddy to the roof of the junior high, drinks a few beers, falls off the roof, lands on his head, and has concussion number 3. And in between 2 and 3, he had been at a facility to address the mental status changes, and they had released him. So he then is at a party in a basement, and they're drinking whiskey and smoking pot, and a friend puts on 2 fentanyl patches on him, and he never wakes up. And these patches were stolen from a pharmacy. Is the pharmacist liable for this wrongful death? That's what I said. I'm not taking this case. But I think this speaks to, you can't come to a quick judgment with this. You need to have more information. So I said, okay, I will take a look at the specifics. The fentanyl patches were outdated and stolen from an unlocked office by a pharmacy technician. Now is the pharmacist liable? Did they report the theft? I don't know if they reported the theft, but I don't know if that's relevant to it. So now how many think the pharmacist is liable? Look, all the pharmacy students. What they know that you may not is that the controlled 2 narcotics, class 2 narcotics, which is 1, are supposed to be locked away in a separate safe or locked drawers or something to protect. from theft. And if you keep going, they came in and the DEA did an audit of the pharmacy after this death, and they found out that multiple doses of fentanyl and oxycodone tablets were missing. 30 to 50% of the stock was apparently stolen by the technician. Now how many think the pharmacist is liable? You know, we have to record every single prescription and keep a running count of every dose of class 2. And I'm working in a pharmacy and I can't account for even one fentanyl patch. I shut the whole place down and do an audit and figure out where it went. Because, you know, really bad things can happen to you if somebody comes in and does an audit, let alone 30 to 50% of their stock. That's just craziness. This one speaks to, again, with all the healthcare professionals, and one of the reasons I picked a lot of pain meds is I think this crosses over the healthcare professions, and all of you are involved with this, and there's been a huge explosion, especially in the state of Maine, in not only illicit use of prescription pain meds, narcotics, but also a huge increase in the number of legal prescriptions that are being prescribed. And we have all kinds of data in the College of Pharmacy because in the state of Maine since 2003, every single class 2 prescription, the data for it needs to be uploaded to this prescription monitoring program with the state once a week. And our professors got access to that, and you run the report, and I'd be happy to provide you with that PowerPoint presentation, just email me. You look, it's like a 20 to 25% increase in the number of class 2 prescriptions just in the last 10 years. The state of Maine's population has not increased by 22%. It's remained fairly constant. So take a look at these pain meds with this case. This was a life care plan where somebody got in an accident and then they were suing, it was a construction company, and they were suing the construction company's insurance company for health care and the pain meds for the next 43 years. Because she was 43 and the chart said that she would live to 86. Look at the pain meds she's on. That fentanyl patch is the highest dose. Opana extended release is oxymorphone, very similar to morphine, 60 milligrams twice a day. And then the immediate release, 10 milligrams, 4 to 6 tablets every 4 to 6 hours, and the prescription was for 672 tablets per month. The street value of this is very similar to oxycodone. It's $1 a milligram. That one immediate release prescription on the street was worth $6,720 per month. What do? You're going to encounter these people. You may not be the one that started the problem, but what are you going to do? And the pharmacist in this case never intervened. Should they intervene? If you're another healthcare professional that this woman is seeing and she gives the med list, are you going to intervene? And what do? It's not a rhetorical question. What would you do if you encountered this? You contact the physician and say what? What are you, crazy? That's not going to go well, I can tell you that.
How much of these are you taking yourself because you're really hiring?
What's that?
Could you tell us what you would do?
I don't know. This is a tough one. I mean, because you have a couple of different options, right? You're the pharmacist and you're filling these prescriptions. What happens if you refuse to fill them? They're legal prescriptions. That person can then go to the pharmacy across the street, or if the pharmacy's 30 miles away, can then file a suit against you because you're denying care. Because you made the call and they said this prescription's fine, fill it.
Would you also think about reporting this to the DEA for diversion?
Absolutely, and that's the problem with this prescription monitoring program in my mind. They're collecting all this data, but the law was written with good intention not to be punitive. It was to identify people who have a problem and get them into treatment programs, and it was also to identify physicians like this and try to educate them. Part of that law is that they're required to bring forth this data and disseminate it, so they do it to the Maine Pharmacy Association, and me being the pain in the butt that I am. How many people has this program identified and put into a treatment program? 0. How many doctors have you identified and educated? 0. So the law was with good intention, but you run into this problem. What do you do when another healthcare professional is doing things that you find inappropriate? And you can try to call and educate them, but what do you do when they push back? You can contact the Maine Board of Pharmacy if it's pharmacy related, and you can identify this, and hopefully they will talk to the Maine Medical Association, and hopefully the Maine Medical Association will talk to this physician and say, what are you doing? Because when you looked at the prescription records for this, there were 2 huge hops where he basically doubled the medication. He went from 120 of this immediate release to 240. And then that was for a year or so. And then he went from 240 to 672. If you look at the guidelines, it says, well, increase 5 or 10 milligrams a day, see how it happens for a couple of weeks. If you don't see continued improvement, you stop. You look for alternative treatments. You know, she had denied physical therapy, and there were a lot of other things. And I thought this would be good to talk about with the diversion, because it does happen. Thankfully, it's a very small percentage of people. You shouldn't be paranoid to treat pain. It's a very small percentage of patients that actually go down the road of addiction and diversion. But there are things that you can look for. When I looked through the prescription, the breakthrough pain meds in the first year or 2 were taken very sporadically. She was taking the extended release reliably every month, and then the breakthrough pain wasn't being filled every month, which you would expect. You're only supposed to take that when the extended release isn't working. But then when he started really ramping it up, she was picking up those immediate release on the day, which means she was either taking the 10 milligram, 4 to 6 of the 10 milligram tablets every 4 hours around the clock, or they were finding their way into other people's hands. So you need to be careful. Are there teenagers in the household? She also had a spouse with chronic pain. She was requesting brand name instead of generic. And you'll find, you look deep enough, the brand name has a higher street value than the generic does. She was able to continue work on these high-dose opioids. Particularly, I jumped in and said, why are you giving this Opana, which is incredibly expensive? Why not go to the generic fentanyl patches? The physician saw my opinion and started the fentanyl patches, but he never discontinued the extended release. When I found that out, I was like, oh my God, I'm amazed she didn't die of respiratory depression, because he didn't start at a low dose, he started at the top dose of the fentanyl. She was refused to be assessed by an independent clinician. When they went there, she said, I'm in too much pain, I can't. And then absence of drug screens and opiate pain management agreement. For those of you who are going to be prescribing these meds, I strongly recommend that you adopt pain management guidelines, and if you're a pharmacist, that's one of the questions you can ask. Is this patient under a pain management agreement? And in those pain management agreements, they usually only one physician can write and only one pharmacy can dispense. And then when they did it, when the side I was working for and the insurance company said, well, where's the drug screens? And they said, well, we haven't done one in a couple of years. And then they immediately did one. And when they did, it showed very low levels of illicit drug and non-medical prescription drug use. Things like THC and Valium were showing up, but she had enough of a time span to know that the drug screen was coming. So the levels were below what you'd, say were enough to then terminate that therapy. So lessons learned. Most of the mistakes are avoidable, and many occur during that transition of healthcare professions, and our professionals are overwhelmed taking care of too many patients. I talk about this when I give the CE to pharmacists. I have a personal number. By myself, working in a store for 12 hours from 8 a.m. to 8 p.m., I can fill 250 prescriptions. And have hopefully I'm not doing that every day, but I can have a high degree of confidence that I'm not making mistakes. Over that amount, I'm not comfortable with that. And I am comfortable with going to supervisors and saying, this pharmacy has increased. You need to put another pharmacist in this store with me. And I think you have to do that as healthcare professionals. If you're seeing too many people too quickly, mistakes are going to be made. Advocate for electronic records we talked about, pharmacist verified orders in institutional facilities. I'll give a plug for pharmacy for those in the other profession. Use the pharmacist. You know, they go to school for 4 years to only learn about drugs. Call them up. You know, start that relationship. They can help you. Document the errors that we talked about, implement solutions. And I think the biggest thing is when you make a mistake, own up to it. You know, be honest with that person. You can diffuse most of them. You are going to have supervisors who are talking to lawyers who are going to tell you don't admit anything, but I don't follow that. It's my license, it's not their license. And I have no problem saying I made a mistake and what can I do to correct that mistake. You know, square up your shoulders, look them right in the eye, and you'd be surprised. I made a mistake when I was first licensed. I was working with an inexperienced technician, and this elderly woman was supposed to get prophylactic antibiotics before a dental procedure. And the technician, who I thought I had implemented a foolproof system, gave her hydrochlorothiazide, didn't sell it to her, gave it to her in an amber vial with no label. Then I find 2 labels and I figure out what took place, and I called her up and she came back down and I apologized up and down and she thanked me. Oh, I would have just taken those, and it was 25 milligrams of hydrochlorothiazide, which probably wouldn't have been bad, but the directions for the antibiotic were 4 tablets, 1 hour procedure and 2 after. She would have taken 6 25 milligram hydrochlorothiazide in a span of like 2 hours, 3 hours. And then professional advice. You know, again, reach out to the other healthcare professionals. Don't work in that silo that we talked about. Purchase individual malpractice insurance. For pharmacists, it's really cheap. For UPAs, it's probably not so cheap. Read and understand the laws and regulations. And if you do have to go before a professional board, bring a lawyer with you. You need to have that counsel there. It will go a lot smoother if somebody's counseling you on what should take place. I'm not saying hide anything, but you should have that legal counsel with you. Because chances are, if you don't have it that first visit, you're going to recognize you need it when you go back for the second visit. Any questions? Well, thank you. I realize I went a little over time, but